enough for everybody. And I want to send out those Word documents to everybody, and I'll send out this PowerPoint to everybody so you'll have it if you like it. We're also videoing these in-services from this point forward, and so if you want to have them for future reference, they will be available. Lots of new faces this morning, so it's good to see you. And so we got several introductions. Ron Richardson's got a couple.
Well, let me just take a minute to introduce our newest physical therapy physician at Hoover. He's a recent UAB graduate, and he's even passed his board exams, which we're glad.
All right.
Ryan Richardson.
All right.
And then also we have a third-year physical therapy student. Started with us yesterday. Real nice guy, and service directors, if you're looking for fresh new talent later this year, you might want to contact Brandon Bunch.
Brandon also did a short-term clinical at Pelham, so I recognize him, so that's good. It's good to have the Auburn contingency here this morning. Emily and Robert are here, and this is Emily's first in-service. So glad to have you here. And Ashley Crisp is our new therapist at Pelham, started Monday. We're glad to have her. And we have a student, Scott Jordan, from Southwest Baptist University in Missouri. And he's doing a great job with us, and he graduates in May.
Yes, sir.
So we've enjoyed having him with us. And Doug.
We've got Rebecca O'Neill joined us also from UAB's class this year, so she's with us out in Pell City. Glad to have her on board. She's also passed.
All right.
Feeling good about things now.
Good deal. All right, who else? Any other new folks that need to be introduced?
I've got Ian Singletary. He's been working with us since December. He also passed his test, so he's good to go. Glad to have him.
Good deal. Anybody else? Is that everybody? If you're new, raise your hand and you have been introduced. Okay, I'll get to everybody. Service director meeting will be about 8:30 to 9. They're going to come in and set up for a picture. We're here about 8 o'clock, so we'll try to end about 8:15, and then have all the therapists back to clinic by about 9 o'clock. So this morning we want to talk about headaches. How many of you guys suffer from headaches? Any type of headache on a regular basis? Raise your hand if you have headaches. Anybody? Anybody? So we got a few. Raise your hand if you've treated headaches on any kind of regular basis as a therapist. Okay? And then raise your hand if you truly feel confident or comfortable treating headaches. Raise your hand. So we got a few. Okay. So headaches can be a little bit tricky, and I'm by no means an expert. I just get to present what I know this morning and what I've compiled from several different sources. And thanks to all the folks that are going to be helping me this morning. But just some quick definitions. Cervicogenic headaches are obviously the ones that we want to treat, or tension-type headaches. Cervicogenic headaches are considered secondary. They come from a whiplash injury or some kind of trauma. And so those are the ones that we can impact. The lifetime prevalence is 18%, depending on the source you look at. For tension-type headaches, that's a primary-type headache. Diagnosis is based on history alone. We can help some of these folks as well. We may not heal them or fix the problem completely, but we can help. And same with migraines. Many times the migraines are triggered by muscular tension or stiffness in the upper cervical spine, and we can help these folks as well, even though this is a primary type of headache. So primary and secondary are the take-home messages from these definitions. And the big take-home is that many of these headaches have a mixed presentation. So I wouldn't get too caught up in the definitions and in the classifications. Hopefully you won't get into any in-depth conversations with neurologists about all this, because they can tend to go on and may disagree with us on some of this stuff. But hopefully it'll give us some tools so we can talk to them. And typically when I'm talking to them, I just say we treat cervicogenic headaches or tension headaches. And I've had the opportunity to treat a lot of Dr. Counts' patients, and she's very open to what we can do for her patients, which is nice. Not all neurologists are. So are there any other referring physicians in town other than Dr. Counts that send a lot of headaches that you guys have seen? Neurologists, neurosurgeons, rheumatologists maybe? Yeah. A lot of these folks aren't getting treated, unfortunately. It's similar to back pain, and the primary care, if they're not educated or open to sending these patients, then they're just going to suffer from them and not get treatment. So if we can educate them, I've included a protocol that you can use for marketing, and I don't have our logo on it. The intention was to print it on your letterhead, and it'll have the logo at the top and have your address at the bottom, and it'll be customized for your clinic. And it's just a general Word document protocol. You can change it if you like, but I've used that some for marketing in the past, so that might be a useful tool for you as well. Any comments about this slide? This is real informal. If you got questions, comments, answers, please feel free to jump in. Tension type headaches, the lifetime prevalence 78%, and for migraines 16%. And the two subtypes of migraines are with and without aura, and then you have many times with migraines you have a vascular component. So kind of some brief definitions, some differential diagnosis. Again, not going to get too caught up in this, but it can be helpful. Hopefully the physicians that we're working with are doing this and sending us the appropriate type patients. But some of this information can be helpful. Here's your symptoms down here. Again, the cervicogenic, usually the decreased range of motion is the big differentiating factor here with the cervicogenic versus not so much with the tension in the migraine. So as always, structure determines function. We're going to be focusing on assessment and treatment of C1 and C2 today, and that's so important with headaches. The mechanics are different here with C1 and C2, and the structure is different. So if you don't know the mechanics of C1 and C2, and you don't know how to treat them differently than the mid-cervical spine, it's difficult to treat headaches. So we're going to spend the majority of our time focusing on these two little vertebrae here. So this is C1, first cervical vertebra. These facets articulate with the occiput. And you can see they're broad, and that allows the atlas just to slide. It slides forward, slides backwards, slides side to side. It's just a big, broad muscle, and it just slides. And remember, you can't palpate, and most people, unless you've got a really thin person, you can't palpate this posterior tubercle. It's too deep. You got suboccipital muscles. The first cervical vertebra you can palpate is C2 spinous process, which is here. So there's just kind of a void here where that posterior tubercle is in the C1 area. You can palpate the transverse processes on most people. So take your index fingers and palpate behind, just inferior to your mastoid process, and just posterior to the margin of your jaw there. And that prominence you feel there that's tender is kind of the edge of your transverse process of C1. So it's a wide vertebra, okay? So you can palpate that, but you can't palpate the spinous process. It doesn't have a spinous process. So then here's the inferior side of C1 that articulates here with C2. And then you have the odontoid process, which is a unique factor for C2. And that allows for maximum amount of rotation between C1 and C2. You remember most of the 45-50% of the rotation in the cervical spine comes from this joint, the C1 and C2 joint, or AA joint. And you have some really thick ligaments in here that protect the spinal cord, which is here. But we always want to be aware of the potential for, especially after trauma, the potential for fractures. The odontoid fracture is not that uncommon. I had a patient fairly recently with a C2 fracture after a motor vehicle accident. So be aware of those things. These aren't real robust, large vertebrae, but fractures are uncommon at the odontoid and at the lamina and at the pars. Any comments? Okay, so as we talked about the ligaments, this is the transverse ligament, real thick. You can see this from the superior angle. Here's the top of the odontoid. So transverse ligament protects your spinal cord, which is a very good thing. And so if this guy gets ruptured, I mean, it would take quite a force to rupture it, but you've got a serious problem because the odontoid comes this way into the spinal cord. So that's what we're going to test for when we're in this area, when in the presence of trauma, to make sure that we're safe to do any kind of manipulation, mobilization, anything really with the patient. Any active range of motion could be unsafe if you had an injury here. And then here is the posterior aspect as well. Well, this is the posterior aspect. Taking off the lamina, and you see the transverse ligament, and then you have the alars, which we'll talk about a little bit too. This is also known as the cruciate ligament. It's in the shape of a cross. The transverse is the thick primary ligament there, and then the alars come in kind of at a 30 to 45 degree angle to the top of the odontoid process. So Josh is going to go over some special tests and some ways that we can look to see if anybody has fractures of the odontoid or issues with these ligaments.
Okay, so anytime we have a patient that's referred, that's been complaining of headaches or neck pain that has been in trauma, we're going to want to test these two ligaments, your alar and your transverse ligament. The first one we're going to do, actually, can I be sitting on this chair? Is sharp purser. Sharp purser is the testing for the integrity of the transverse ligament. Again, as you just saw in the anatomy, that odontoid should be uptight against C1. And this is going to try to test that integrity. So what you're going to do, your posterior hand's going to come and stabilize this on the spinous process of C2. Okay, you're going to use your anterior hand and come up on the forehead, and you're going to slightly nod the patient. Okay, slightly nod the patient. And what you're going to do is you're going to give a posterior force with your anterior hand to try to slide C1 back into C2. All right, you should not feel movement. All right, that's a negative test. A positive test is if you get translation of that head, you have a soft infill or you have a give there, then we think that we have that odontoid has subluxed out. Another positive test will be a clunk, that odontoid coming back and clunking back into position. Okay, and finally a positive test would be a relieving of symptoms. If you do this, you get a slight translation and that patient goes, whoa, everything feels better. You have a problem. All right. All right. That patient is not appropriate to mobilize and test, and they need to be referred out. Okay. Sharp purser. Good. All right. Let's go and lay down on your back for me. Good. So when we're testing the alar ligament, you're going to have the patient supine. All right. You're going to put them on your therapy pillow. All right. Depending if it's small or extra large. Again, you're going to do a slight subcranial nod, or just drop that chin down just a little bit. You're going to use your index and middle fingers to palpate on the spinous process of C2. Okay, again, that's your first big spinous process that you can feel. So slight nod. I got my index finger and middle finger on both sides of C2. I'm not stabilizing though. I'm not preventing motion there. I am searching for motion. And what you want to do is you want to side bend that head, and you want to feel C2 immediately move into your contralateral side. So I'm right side bending, and I want to see C2 move immediately into my left hand, my left fingers. Okay. So what I'm doing is I'm putting my ipsilateral side on slack, my contralateral side are pulling taut, and I'm testing the left alar ligament with this test. If I don't feel immediate movement, then I can suspect that ligament is damaged or lax. Again, that's telling me I need to use caution with any mobilizations up in the upper cervical spine. Okay? And then I can do the opposite side. I want to feel immediate movement in that C2 into my hand. Good.
So because of the attachment there, the odontoid is moving the occiput up here. Any slight movement of that occiput, kind of just think about rolling a bowling ball, kind of tilting it, should cause, like I said, immediate movement right there because of the attachment. So if you don't feel that, if it's lax, sometimes there's too much guarding, too much swelling in the area, so it can be a tough test to administer. But you know, if there's any questions, sometimes we've had questionable, and we send them back to the physician for just say, hey, we had a questionable test, and usually they're appreciative of that. And I think I might have had one that showed up with some positive stuff. I might have sent 2 or 3 back to the doctor, you know, since the past few years.
Guarding, intense guarding will make these tests invalid. So
Yeah.
you can't have intense guarding with those.
Okay, so vertebral artery testing, you probably heard some about this. I won't say, Paris teaches it heavily, and he's still a proponent of doing it, even though it's not valid or reliable, which doesn't make a whole lot of sense. But he still recommends doing it, even though he says there's a lot of false positives. He admits there's a lot of false positives, and he also does another test. You got the traditional vertebral artery test, which I won't go over, but he also does a bilateral extension test for vertebral artery occlusion. Again, not really valid or reliable. So an alternative is screening for risk factors for coronary artery disease. And this has been shown to be more valid and more reliable for determining if somebody's going to have a vertebral artery issue. When you have a neck questionnaire, And this is a good, if you're going to treat a lot of neck, a lot of headache, I don't use this on a regular basis. I do this more verbally. But any of these things, all these questions are screening for coronary artery disease, atherosclerosis, all those factors that you want to kind of screen for if you're treating neck patients. So hopefully we're doing this kind of stuff anyway, and at least listening for these type of red flags if the patient says these type of things. So those are just questions that will kind of clue you into to the fact that there might be an underlying issue. You might want to go slow with these patients and that kind of thing. So I'm not a big proponent of the vertebral artery test, but again, you can do it if you'd like. There's just not a lot of research to back it up. Of course, your traction and compression, you can do those tests. Spurlings, you don't have to extend. Most of the physicians will side bend extend and really compress and get in there hard, but you can just side bend and compress, and that's kind of a positive for radiculopathy. And then, sorry, this is a little bit random, but you also have a headache log. That's one of your handouts, which is a good tool if you're treating a patient. If they haven't gotten one of those headache logs, if they come from a primary care, it's nice for them to be able to track their headaches, and hopefully you can help them with differential diagnosis. A lot of times, if you're not logging those headaches, you can't. It's hard to find a pattern to them. It helps with triggers and lots of other things. So it's good to help your patient log those headaches and give you more information, give them more information, perhaps their doctor more information. Most neurologists use the headache logs, so that's just another tool if you'd like to use that. Another thing to think about is asking your patient, if they've had trauma, have you had an open mouth x-ray? When the mouth is open, it gets the teeth out of the way and you can see the odontoid. And so if they've had trauma, I would ask them that. Again, sometimes it's missed, so it's not always perfect, but open mouth x-rays are a good idea. Again, you kind of have to be careful talking to the physicians about this and saying, requesting this kind of thing or questioning, what's been done. But again, if you're going to treat the upper cervical spine, you need to think about these things. This is another good tool that James Dunning is a proponent of. It's a Canadian C-spine rule. We didn't get this in school, but this is a good little quick screen. I hope it's kind of busy. I hope you can read it. But any high risk factor which mandates radiography. So if the patient's older than 65 years, do you know how to focus this? Is there a focus on this? If the patient's older than 65 years, they're at high risk. Dangerous mechanism of injury or paresthesias in extremities. And down here, dangerous mechanisms are defined a little bit more. There we go. Perfect. Defined in a little more detail, like a fall from a certain height. So you can look at those. If they don't have any of these three categories, you move on to this block, and this would be just a simple rear-end motor vehicle accident, ambulatory at any time, delayed onset. So these are lower risk things. If they don't have any of these things, you can move on to this one. If they are able to actively rotate their neck 45 degrees to the left and the right, then you don't need radiography, assuming they haven't had it. If you get down here and they can't rotate, even if it's a low risk category and they can't rotate 45 degrees to the left and the right, then if they're unable to rotate, then you need to request radiography or be thinking about that. So this is just kind of another quick screening tool that's useful. Any questions about that? Comments?
I was just going to say one more thing about the vertebral artery test. I think, even if you do like that test, one thing I've heard kind of mentioned in the course I've been to is that, I guess, unless if you're planning on doing like some subcranial work that's like real aggressive up top, that's a pretty aggressive test. And so sometimes just doing the test can be kind of more aggressive than what your treatment will be. So, if you're thinking, you're just kind of maybe doing some soft tissue that first time or doing something that's kind of real general to the subcranial region, you may put that test off like to another visit until you get ready to do something kind of more, manipulation and mobilization of kind of that subcranial region, versus putting your patient through that and making them dizzy and that kind of thing.
Yep. And the other thing to be aware of is if they come in, they're restricted in their mobility, and you free up, say you test the vertebral artery, it's negative, then you free up mobility, then you might take them into a range where it's a positive. So something to think about as you free up mobility and get them more motion, it could happen as you progress in the treatment. All right, good comment. Okay, Mr. West, come on up and talk about some mechanics of subcranial spine.
Okay. We don't have time to go into all the specific arthrokinematics, but this is a basic overview of the mechanics, which this is really all you need to know to be able to assess and treat. So we'll start from the top down in the upper cervical region, also known as the subcranial region, which, as Nathan said, this is where we're really focusing on the headaches. The two things you need to remember is the atlas always follows the occiput, and the coupled motion in the upper cervical spine is opposite. And so if I rotate to the right, the C1 will follow the head. So you're getting rotation of C1 on C2 to the right. And you'll also get side bending of C1 on C2 to the left, opposite the right rotation. That's real important, especially with the active range of motion testing that Nolan's going to talk about. Because if you ask someone to rotate to the right and they can't keep their eyes level, then it's kind of indicative of a subcranial hypomobility. And then moving down into the mid-cervical and lower cervical. At C2, C3, you start to get your facet orientation of 40 to 45 degree angles, and that goes down to C7. And so when you rotate to the left, you're going to get coupled motion in the same direction. Rotation left, side bending left. And so right side facet will go up with left rotation, and you'll get side bending and rotation. In the upper thoracic spine, which is T1 to T4, the facet orientation is still like that, similar to the cervical spine. So you have the same mechanics. And then below that, from T5 down, the facet orientation starts to change from about 45 degrees to more vertical. And so you get coupled motion in the opposite direction. So that's it.
Sure. Explanation? All right. Josh, you're gonna be my subject here. Yeah. This guy, he's not fixable. All right, so I'm just going to go over it from the standpoint of just our general active motion and looking for specific things in the upper cervical spine that we can treat with these techniques. So like Wes said, these mechanics that he went over, we're going to actually see them here. All right, so you can see Josh he's already kind of tilted to the right. He's side bent to the right. And there's probably subcranial spine. All right, Josh, turn your head to the right. Look over your right shoulder as far as you can. All right, you can see he's limited, and he's side bending to the right. So he's not able to subcranially side bend to the left to keep his eyes level. So we're suspecting a restriction, AA rotation right or OA side bending left there. So when Daniel does the passive test, we're gonna confirm or refute that hypothesis. All right, turn your head to the left, and that's a little bit better. He goes further, his eyes stay level, so we don't see as much of an issue there. All right, back to the center. Tilt your right ear towards your right shoulder. Okay, that's not bad. And what we're looking for here is that when he tilts his head to the right, this is non-functional side bending, that he rotates to keep his eyes forward. Tilt your head to the left. He doesn't do as well here. He's limited. So that could be mid-cervical spine, or it could be he doesn't have the ability to rotate at his AA to keep his eyes focused to the front. So just tilt your head to the right. What you'd really be looking for is somebody tilts their head to the right and their chin's over here. So they're not rotating at the AA to keep their eyes facing towards the front. Does that make sense? Okay. All right. So you look at different things in the mid-cervical spine, but we're focusing on subcranial, so that's basically what you're looking for with those tests.
One or two more things. When you flex, you can look for deviations.
Well, you can look down, okay, and this is kind of not a great example because he's side bent to the right normally, okay, but if he's in neutral and he looks down and he deviates to that. So he's deviating to the right, okay? Then we're going to suspect mid-cervical hypomobility on the right. He's going to deviate to the side of the restriction in the mid-cervical spine. And that makes sense because on the left he can move, so he's moving down there, but he's restricted on the right, so he's going to deviate to that side.
Yeah, and then the functional, like the chin.
Okay, just a quick screen just for gross limitation. you want, if you're just, want to do a real quick thing, to do a treatment and then test, retest, this is good. All right. Try to turn your head and bring your chin toward the middle of your collarbone there. Okay, so he gets close. It's not bad. We could look at that and then do a treatment and reassess it. Now go to the right. A little more limited there. There's a little more space there between his clavicle and his chin. Look back forward. Okay, look down. And you want to be able to basically touch your sternum or get really close. He's pretty good there. So again, just those are quick screen tools you can test and retest with.
So if you can do that, if you can take your chin down your collarbone with no problem, that could be a sign that you're good in the mid-cervical. But then if you don't have a pure subcranial rotation, it could show that you have a subcranial restriction versus a mid-cervical restriction.
Okay, so I'm just going to kind of go over some of this passive intervertebral motion with y'all. Josh will get you lay down here. So one of the first things I usually do when checking the subcranial spine is the kind of OA nodding or subcranial nodding test. So when you do this test, you want to think about the axis being kind of through the ears here. It's not a real big motion. And as you could expect, with a lot of our patients' postures kind of being in a forward head, kind of extended posture, a lot of your patients are going to be kind of limited on what I call the forward nod or the flexion test right here. So you just kind of work around the axis right there, little nod right there. You can also do a backward bending like this. And like I said, most people are going to be a little bit more limited with that forward nod test, and Josh is a little bit limited there. This is something that I'll do occasionally just to kind of figure out maybe if there's a bias to one side or another with that test. You can just kind of take your patient and rotate them, about 30 degrees or so, and then just kind of do like a little nodding test to either the right side or the left side, just to see if you can feel a little bit of difference there. So in this case, he feels a little more limited, kind of with a little bit of rotation towards the right side. So then you can find a restriction there. The other test that's up here is the subcranial side bending test. So in this case, your axis is going to be kind of through the nose right here. So you're kind of spinning around the nose. I think you want to be careful with on this test is the amount of motion you have here. So just realize that those subcranial joints just have a little bit of side bending. So I guess if you get in here and you do too much of a motion, what you're doing is you're getting down here into the mid-cervical spine, and you're kind of assessing more mid-cervical than subcranial region. So it's just a gentle test right there. So getting back at kind of some of the things Nolan was talking about during the active mechanics, this really gives you kind of a good feel for what you're actually feeling here. You can kind of, by this test, kind of figure out, if there's a limitation on the left side or the right side. This test isn't necessarily as specific to, OA or AA. It just kind of gives you an idea that there's going to be some sort of restriction kind of in the subcranial region. So if you want to get a little bit more specific, there's kind of two tests you can do. You can do kind of an AA test, and you can do kind of an OA test. Nathan was telling you earlier, to kind of get in here to find that transverse process to C1, just kind of slide down here into the masseter, and it's going to be a little bit behind the mandible right there. Wes was telling you earlier, the subcranial mechanics are coupled in opposites in the subcranial region. So if you think about it, if you turn him to the left, that's going to be the same as subcranial side bending to the right, at the OA joint. So, as we talked about, the atlas is going to follow, whichever side the occiput is turning to, or side bending towards. So, as I rotate him kind of to the left like this, essentially what you're doing is you're creating a little bit of subcranial side bending. So when I take him to the left, if I've got my finger on this right transverse process, I'm checking for that right subcranial side bending at the OA joint. Does that make sense? All right. So kind of the same way, if I take him kind of back here to the right, I can check for kind of some subcranial side bending on the left side. So I'd want to pair that up with my test before. Typically what you might find is if that OA joint is limited, you usually find some sort of restriction coming to that side. So if I took him into side bending here, and found a little restriction with left side bending, I may find that when I rotate him to the right, I may not feel as much jump right there on that atlas. So, and just a little tip to kind of help figure out what that jump feels like. If you just put your hand just on the transverse process, sometimes you can't feel that jump as well. So if you make a little bit of contact with kind of his skull right here, and just kind of let that finger drop off right there, you can kind of feel a little bit more motion sometimes because you can feel the motion of the atlas relative to what's happening up here in the cranium. So that's just a little pointer that will help you kind of find a little bit more motion when you're doing that test. So
Just to clarify, you're feeling for the atlas to come into your finger.
into my fingers, right? Yeah, kind of towards that side. So, and sometimes, I mean, you'll feel like motion on both sides, but it's much more kind of obvious on one side or another. And so in that case, you have hypermobility on the side where you're not feeling as much jump. So the other tests, there's kind of two tests that you can do for the AA joint. I guess the more traditional test would be just to take the person into full side bending. And so one thing you want to do on this test is make sure you keep that person in neutral as you kind of take them into a little bit of side bending. And so because of the mechanics of the upper spine, if I take him into kind of left side bending, what I'm doing is I'm locking out all the lower mid-cervical joints, and I'm kind of isolating the kind of upper cervical, the AA joint. So I'm going to kind of hold him in side bending, and what I don't want to do is I don't want to lose the side bending as I rotate him this way. So I'm going to kind of hold that amount of I guess you could consider it flexion of the spine and side bending, and rotate him to the opposite side, and just kind of assess that infill right there. So just make sure you don't lose that, because sometimes what you can do is as you're turning, you can allow him to extend or lose a little bit of side bending. So you just want to maintain that position that you have him held in, and then kind of turn him to that side, and then you'd want to take him to the other side and compare with the other side. So as we talked about earlier, the mechanics are opposite in the upper cervical spine. So if I take him to the left and turn him to the right, I'm kind of assessing AA rotation of this left AA joint, and same thing with the right. But if I side bend him to the right and then rotate him to the left, I'm assessing kind of the mechanics of the right AA joint. So then kind of another test you can do that's a little bit modified, and sometimes you might pick this like certain test depending on kind of your patient tolerance for that position. So this could create a lot of stenosis in certain patients, so it may be uncomfortable to get them there. Another test you can do is just to kind of flex the spine. So you're taking up all the mid-cervical motion here, and then just take them into a little bit of rotation here. Same thing with this test. If you're kind of rotating them in this position, you want to make sure that they don't drift off axis. So when they have subcranial tightness, they may try to start side bending here. You want to make sure you kind of hold them in a position where you don't allow them to kind of side bend subcranial as you're taking them into that certain position. So this is probably an easier position for y'all to see. As I take him here, he's much more limited with that AA rotation than going this way. I would consider that to be kind of stiff on the left AA joint based on that test right there. So I think that pretty much covers all this.
So you determine there's a subcranial restriction, and we've got to figure out, in order to treat it appropriately, is it OA or is it AA? And so if you treat it specifically, you're going to have more successful results. So that's the whole point of all this. Okay, Roberto.
Josh, you got a headache?
Fix him.
Don't leave me this way.
Okay, so as far as treatment, so now thinking about mechanics, so active movement and then passive movement, and is everything fitting together, and then now putting it all together and trying to come into treatment. So first one, subcranial side bending, muscle energy technique, just non-specific. So that passive side bending test that Daniel was talking about, you can just take them into that passive side bend and kind of find that end range where they're at. And then for any muscle energy techniques that you're doing, be very specific with the cues that you give them. So instead of giving them, okay, go ahead and push against me, Because if you give them that, then of course they're going to fight against you just like any patient would, right? They're going to push and try to overpower you. And obviously with all these muscles, there's a lot going on. A lot of times they're flared up, tiny muscles, so they only need just a little bit of activation there to have an effective treatment. So take them into that side bending, and then put your thumb up here and say, I want you to match my force. And then you have to push gently, and then relax. And what I'll tell them too, typically, is I want them to kind of ramp up about 3 to 5 seconds, and then ramp back down, so you're kind of easing into it. So it's not pushing really hard, just side bending, hold there, now match my force, match, and then back down, and then relax. And then always want to come in and retest them and find out what's going on as far as what kind of changes you've made there. So AA, MET flexion, like Daniel talked about, bring them up into flexion, and then we want to take them into rotation, and then we assess kind of where he's limited, take him into that end range, and then right here say, okay, I want you to match my force, and ramp up, and then ramp back down slowly, good, and then back down, and then reassessing them through that. So I usually do about 3 to 5 treatments, about 3 to 5 seconds, and then reassess them after that. Sometimes when we talk about those patients who are real heavy in guarding, and you bring them up into flexion, they're sitting here holding and trying to help you. A lot of them want to help you. They want to, they say, oh, let me make this easier on him because I've got such a heavy head. Or they're just tense or tight or restricted, or they're not sure what you're going to do. Whatever it may be, they may be guarding. And you can sense that. You can feel all that tightness in there. You can also bring them into side bending and do that same technique. Does that make sense? So same way, same idea. You're still trying to lock out the cervical spine and treat AA there. So next one, OA, nodding. So you're going to take them and you're going to bias. So we talked about that 45-degree angle of OA, left or right. You want to take them into just some slight rotation to bias one side or the other, whichever side you're trying to treat. And then you'll come down and you'll block C1. And then you're going to come down and you're going to put your hand right up here on their forehead. And I'll say, all right, I want you to match my force. And I'm trying to take them into that forward nod. Sometimes I'll say, oh, you're going to lift your chin up to the sky. That kind of motion, just trying to lift up and then relax. You want to go ahead and do the rest of your way? Just kind of while you see that. Yeah.
Okay, so if you find a restriction in OA nodding, not odding, but nodding, and you want to treat that manually, you remember that to get OA flexion, you roll anteriorly, you glide posteriorly because of the convex and concave rules. So what I'm going to do is take my right hand, and I'm going to hold his occiput. My left hand, I'm going to find C2 because that's your first big landmark. I'm going to go just above it with my thumb and my forefinger and try to stabilize right there on the posterior arch of C1. So I'm going to be right there. And I'm going to create the roll with my right hand. And then, because PT is a contact sport, I'm going to get my shoulder right on his head. And if you have somebody with, as Nolan learned the hard way, if you have somebody with like hair gel or something, put a towel over their head.
Makeup with
Yeah,
females?
makeup. Did you wear a lot of
Otherwise, you'll
makeup today?
just have makeup right here on your shoulder the rest of the day.
So I'm going to stabilize right there. I'm going to roll with my right hand. And then I'm going to give that little posterior glide with my shoulder. So I'm creating a little OA flexion. Right there. And that's pretty effective for some OA, to free up some OA. Another thing I just wanted to throw out, if you've got somebody with that real forward head posture, which we see a lot of people with that, they've got OA extension because they're trying to keep their eyes level. So if you give them some OA flexion, they're not going to walk around looking like this. You've got to find the other cause of why they're walking around like that. So usually it's some thoracic extension restriction, so you've got to treat that as well. Just throw that out there.
All right, so Atlas Press. This one is in order to try to improve some of that OA mobility. And you're gonna, I'm sorry, hey, slide over this way for me. So with this one, you're going to want to stand on the opposite side of the side you're trying to improve side bending. So if I'm trying to improve his left side bending, I'm going to stand on his right side. So I'm going to take him over into left rotation. I'm going to find that TP of C1. And then I'm going to come over on his side, and then with my MCP, I'm going to come right onto that, and then come under his head. So now my forearm is underneath his head, And then my finger's gonna come under his chin right here just to give him a little bit of security. And then I'm gonna bring him, side glide him towards me and side bend away. And then we're gonna just do a direct lateral press to the left, okay? I know it's kind of tough to see here because I'm in the way. So let's go over this side. So if we were treating him, we're treating his movement with, in order to try to improve his left side bending. But now, for Josh, but now just so we can see kind of the opposite. We're going to come on this side, find C1, roll him back over, come underneath. My forearm is now underneath his head, chin here. Side glide him towards me, side bend away to lock that up, and then direct lateral press, okay? It's a tender technique, so let your patients know it's going to be a little bit tender. But then obviously if you can, test and retest, you can show them the effectiveness of that technique, right?
So just to simplify this technique, if the axis is not moving that way, just press it that way. Real easy. And if you played running back in high school, this holds real easy for you. But another one, if you just hook on the posterior occiput here with your hollow just distal to your MCP there, and hook on the occiput. And if you want to free up one of the OA joints, like I'm going to try to free up his left OA joint, pulling him in tight to me. Rotate, I side bend towards, rotate away, and I just do a little quick distraction. And you don't get jabby with this hand. You just make good contact with the hand. Do a little quick rotation. It's just a distraction. Okay. So rotate away, side bend towards. And that way you take up all the slack, and it's making it as specific as possible. Good tight contact, and then just a quick little HVLAT, just a gap. It's real nice. Sometimes it pops, sometimes it doesn't.
Got it.
But it's a nice little free up quick manipulation.
So the test retest. So now we're going to do a seated AA rotation. So this one, we're going to come in and with our posterior thumb, and make sure you protect your thumb. Obviously, you don't want to come in and have too much extension there. So try to stay in neutral here. Protect yourself. So you're going to come on posterior arch, lamina of C2. And then obviously tell your patient, explain to them what you're doing, because you're going to get real close to them here as well. You don't want to come down on their face, because then they can't tell you what's going on or talk to you or breathe or anything like that. So,
Robert, just to clarify, you're on the right side right now, right?
Correct.
C2.
yes. And then come across their forehead, and then you can draw them in towards you to gap that right side. And then you're going to rotate till you find that restriction. And then you can do, you can press anteriorly with your thumb. And it's a tender technique. But so you want to obviously talk to them, let them know what's going on and what you're doing with them. You can also do a muscle energy technique, so take them in, lock them up, rotate, and then tell them I want you to match my force as you're taking them to a little bit more right rotation there and blocking them. Okay?
And you can bias either side with side bending, so you can treat the left or the right if one was tighter. So he's blocking C2 with his thumb and then rotating over that. So you're blocking C2 and taking everything else the opposite direction. This is a great technique for Josh. We've done it about 100 times over the years to keep his right rotation as good as possible. We haven't fixed him, but we keep his symptoms at bay. So that's a good technique. It's a strong technique, so don't be gentle.
This is another technique to treat an OA flexion restriction. And basically, it's just, instead of mobilizing from the top down, you're mobilizing at C2. So same kind of hold. You're going to get the head like in a football hold right here. Tell the patients, because you've got to get up close and personal. So now I'm stabilizing with my right arm, and I'm going to do a little anterior glide of C2. So I'm right on the side of C2. I'm going to do a little anterior glide. I don't think this is as comfortable as the other one, do you think?
No.
No, does not feel as good. But sometimes it doesn't work the other way, so it's good to have other. But basically, that's what you're doing. You're creating a little anterior glide of, posterior glide of the occiput, anterior glide of C2.
Any questions about that? There's Okay. Muscles, obviously, hugely important in this area. You gotta know these suboccipitals, pretty much, O's and I's for sure. This rectus minor attaches to the posterior arch of C1. It's deep. You kneelers won't be needling this muscle because it's too deep, but you will needle rectus capitis posterior major, superior oblique. This guy is also known as the headache muscle from what I've been told, and it's pretty far lateral. So your traditional suboccipital release grip doesn't get that superior oblique, or it's difficult. So I would treat that unilaterally and just roll the head over one hand and kind of hone in on one side at a time on that one. And that's been an effective way to get that superior oblique for me, and I like that one. And a lot of times if they're not too irritable, do some cross friction over the tendon insertion where it inserts into the occiput, and that's effective. Again, if they're not acute. You'll also needle this guy, it's super deep, attaches to the spinous of C2 and the transverse of C1. And you'll come right down kind of at 45 and hit the lamina of C2. So that's probably the deepest, scariest muscle you'll needle in FDN2, but it's a good one, and it's very effective. So you'll get all three of those. But these muscles in particular are typically the most involved with headaches, and you've probably seen that in your experience too. But don't forget about SCM on the anterior side. You can do muscle play techniques, strumming. You'll needle it. A lot of these muscles respond well to needling with stem, so you'll do a lot more stem in the second level. Levator and traps, if they're tight, we can stretch them. We can do hold relax. We can do spray and stretch. And then a lot of the erector spinae as well can trigger headaches. The good thing about needling with the erector spinae is when you needle, you get all those layers of muscle, which is so nice because you can treat so many different layers. If you're going after this guy, you've got to go through all those other layers. And then another technique that we learned in level 1 needling is just to kind of peck the upper erector spinae where they attach the occiput there, kind of peck with the needle, and that's very effective for headaches. So, but again, if you're not a needler, or if the patient won't allow you to needle them, can't get consent, or they have a contraindication, you can do cross friction on those muscles. You can do ultrasound, you can do onto. We've done onto, kind of trying to get these insertions before if they're inflamed, irritated, and had a little bit of success doing that. So again, here's some of the techniques that we have in our repertoire that we can use. You can do ice massage if they're acute, irritable. Sometimes I've done ice massage and then needle, and that works pretty well sometimes. Any other thoughts on how to get at these muscles? Any other great techniques that you guys are using? All right, so just some common trigger points. You have the suboccipital trigger points, again, lateral head and eye. And you can ask the patient, where's your headache? Well, it's behind my eye. Okay, you might want to look at the SCN, you might want to look at the masseter, which is a commonly forgotten muscle for headaches. Up here at the masseter. Obviously the temporalis has what you would expect as the referral pattern, but you'll be needling that in level 2. You'll needle the masseter, trap, and then here's some of the semispinalis and some of the splenius muscles here in the cervical paraspinal. So interesting referral patterns, all closely related to headache. So you've probably seen some of these presentations. This is Travell and Simons, I believe. We have these charts in our clinics now, been very helpful for trying to determine which muscle is at fault based on where the pain is, where the trigger pattern, referral pattern is referring to. But you can get these online, and that's a nice resource. They also have probably a paperback book that you can look at for these referral patterns, which is pretty nice. So again, we all know this. This is what we try to teach our patients, but this is a good visual aid. I showed this to a patient yesterday, and she said, "Whoa, 42 pounds." So think about this as we're trying to educate our patients. Don't forget about Yanda's principle here, the cross principle, the weak cervical flexors, along with the lower trap and rhomboids, and then the tight muscles going the other diagonal. So this is, I think, important, obviously, for forward head posture and treating this subcranial spine. Doug's going to talk about a few strategies for helping with this.
I think we need to pick on a new person, so Ryan, I told Becca I wouldn't pick on her, so I'm going to pick on Ryan. We're going to do the deep cervical neck flexors, and Has anybody ever used one of these? Okay. So we're gonna put this. I kind of laughed. Nathan asked me to do this, and we've been studying for the OCS, a couple of us, and this is like a big thing they've talked about in the research. So it's been kind of fun.
Can you do the same, I mean, will the numbers work with the blood pressure cuff?
I think it
Exactly
should.
the same?
I mean, I think it should. That's a good question.
It's supposed to, but usually the
The
tubing.
tubes are too
Tube's
short.
not the, yeah. So we're basically gonna put this underneath the curvature of his C-spine, and then we're gonna pump it up to 20 millimeters of mercury, and that's gonna be your starting point. So think of this almost like the equivalent of an abdominal brace in the lumbar spine. We're just gonna work those deep neck flexors in the Okay, so we're gonna give it to him here and let him see our starting points and get up to 20. And then the idea here is we're looking at just, a lot of our patients are motor morons, so we're gonna give them let's see, get down the notches. There we go. Okay, so you'll give it to him, and you're going to instruct him to try to basically flatten his neck out. Now, you don't want him using any accessory muscles. So you don't want him using SCM or trap, any accessory muscles. We're trying to really just get him just to do that little nod. And the first step you're going to try to get to is 22 pounds, or 22 millimeters of mercury rather. So when he gets to 22 millimeters of mercury, we're going to count for 10 seconds, see if he can hold it. And you're kind of watching. So obviously we'd want to have him a little de-rogue here. We won't make him do that. But you want to watch and make sure that he's not engaging any of those accessory muscles. Okay. If he can hold the 22 millimeters of mercury 10 seconds, then you give him a 10-second rest. And actually, I think you're supposed to be doing it co-flying, so go ahead and bend your knees up. So you can give him a 10-second rest after he holds it for 10 seconds. And then the next step will be to go to 24 millimeters of mercury, hold that for 10 seconds. Here again, still watching to see if he's getting any accessory muscles. And you're going to repeat that process up to 30 millimeters of mercury. I believe the research says if you can get to, I think if you can get to 28 to 30, that's kind of a normative value, so that's good. He's got good control over those muscles. If he's, only getting, say, to 26, if he starts incorporating other muscles, if he can't hold it for the 10 seconds, then you know that you've got some deficient deep cervical flexors.
So that's 28 to 30, hold for 10 seconds?
Hold it for 10
So that's
seconds.
considered normal?
Yes. Yep. Slightly efficient, okay.
Can I say one more thing over here?
Yep.
Talking about the deep cervical neck flexors, you can do soft tissue on these. It's kind of like a mini psoas release. You come in from the opposite side, obviously clearance from the patient, and they're not uncomfortable. You can just slide in lateral to the trachea with 2 fingers or 3 fingers gently, and you can contact the anterior surface of the intervertebral bodies, and then the muscle layers are going to be right in, just anterior to that. You just do a little mild, faster release. You can do inhibitive pressure. You can kind of angle your fingers up and down just like you would with a psoas release, and release those muscles if they're hypertonic. So many times they're going to be hypertonic after a whiplash injury, so they're going to be weak as well. So you release them a little bit, get them freed up, and then retrain them with what he's talking about. Works great.
Another thing you can do when you're doing that exercise, if somebody's neck is really irritable, they might have pain just holding the monitor up where they can see it, so you can put some pillows on their chest and let them rest their arm. That would be effective.
Okay. Next thing, just fill it out for a minute. We're going to do more of an endurance test. So similar fashion here. We're still going to try to get them to engage those deep cervical neck flexors. So you want them to do that little bit of a nod here again, trying to avoid incorporating any accessory muscles. And then you're going to try to get them to lift basically about 1 inch off the table. And then you're going to have them hold that. You can slip your hand underneath there so that you can feel as he starts to give. And you're just going to time him here and see if he can hold that. Now, in the literature, they talk about looking at the creases in the skin. So you want to see, some folds in in the anterior side of your neck. They even tell you to, I think, draw lines on it so that you can see it when it separates. But basically, you want them to hold here. Watch what the musculature is doing. If they start to lose it, I'm going to feel his head come back against my hand, and I can about assess how long he was able to hold it for. Yeah, the normative values in the literature were kind of across the board. I think for men, they said somewhere around 40 seconds, but that was plus or minus like 20 seconds. So, and then women, it was like 30 seconds. So in my mind, what I would use this for is just as a test-retest value, so I could see, you know, hey, on evaluation, he was able to do it for 20 seconds. Now he's able to do it for 40 seconds. So I see that improvement in endurance of those muscles. Okay. Any other thoughts on that one? Questions? Okay, you can sit back up. And then from a corrective standpoint, Nathan was showing the Yonda exercise. So there's any number of things that you can do to work rhomboids, middle trap, lower trap, as well as some of those deep cervical flexors. Let's go put you in quadruped there. So this is kind of a fun one. You can get a little bit of that against gravity type of feel. So you can get them in a good quadruped position, and obviously, you know, how soon you put somebody in this position is dependent upon how much motor control they have. So you obviously wouldn't want to go too quick to some of these positions. You want to make sure they've got good control, maybe in standing or sitting, before we go into quadruped. But from here, you can have them do that little bit of a chin nod. And then you can, even from that standpoint, you know, work them into, you know, doing some light extension from there. So if you get that little chin nod, and now try to extend up a tad, and you can start engaging, you know, some various muscles at the same time. So that's a fun one going against gravity. Let's go ahead and lay flat. You're everybody familiar with your T's, your Y's, and your W's? Okay. Some of the research lately, I know Mike Reinhold, if anybody reads his blog, he's kind of gone anti-T's and Y's lately, for the simple fact that he said he didn't think that you're able to isolate as well as you think you are. So he was really anti putting them on a ball, which I've done a lot of, or anti even doing it bilateral. He was talking more doing unilateral. So at any rate, I think we'd all agree that, you know, I think we're at least incorporating some of the muscles that we're wanting to work with these exercises. But there again, you might not throw them right onto the ball right away. You might not throw them even prone or you know, unstable position right away. But just go ahead and slide over the side. And so obviously your T's are just coming straight out. And I like to do a lot of times just give them some feedback. We were talking about this yesterday at the clinic. We're going to come back down. You know, I think sometimes the therapeutic exercise piece gets overlooked. You know, we hang up on a lot of the manual piece, but the exercise instruction is just as important. We were joking, where's Claude? We were joking about his experience at Champion after his knee surgery, and, you know, hey, go over there and do this, this, and this. And we've all heard patients talk about that. We need to make sure that we're instructing them properly, giving them some tactile feedback in what they're doing, and that's a great Medicare documentation piece. You know, patient-required tactile feedback to perform exercises properly. Okay. So just a little compliance thrown in there as well. So you're aiming for that mid trap with the T's, with the Y's. Ooh, a little shake. Too much study and none of work. Now with the Y's, obviously, you know, you're getting a little more lower trap in there. And then your W's, you can do kind of coming up there, and you can even get a little extra rotation, a little rhomboid kicking as well. Okay. Anybody got any deviations on those they like to use, or?
You just gotta make sure that they say that little chin nod is cervical neutral when they do this, because if they don't, like if his chin was propped up like that, they're gonna wind up real sore.
Yes, yeah. So give them a face plate, towel roll, you know, something to put their head on. All right, you can sit back up. Serratus, I saw a good serratus actually the other day. They had them doing a supine. Actually, good lay supine. Kind of liked this one. I saw somebody do it. I don't know where I saw it. They actually gave them a band around both arms and had them do kind of an alternating. So go ahead and hook lie there. And so with this, you can have them go ahead and engage those cervical flexors during your little nod, and then go ahead and hands down here. So they had a band around both shoulders, and had them basically kind of doing coming up. So you kind of a punch as you flex, and then coming back down and alternating. So you're getting a little bit of, it's working it unilaterally, but it's requiring a little more coordination, a little more work. So I thought that was kind of an interesting one from a serratus standpoint, but still making sure, and this is where you give them that feedback, making sure that they're not incorporating too many accessory muscles, upper traps. We see a lot of people, kick those upper traps in and start compressing things.
And even just with your regular supine punch, instead of doing 90 degrees, go 100 degrees, you'll recruit a lot more fibers, it's a lot harder, and it's a much better punch.
Cool. All right, any other thoughts, exercises anybody likes to use?
Serratus, I know we've talked about this exercise before, I call it a spurs, scapular protraction or foot rotation.
On
that
the
you-
wall?
On a ball, you're punching into the ball.
And you want
And
to,
you
yep.
have to really watch the cervical position with that, even if you're not treating the C-spine, you have to watch the cervical position with that. That's really good, but you can also do it in quadruped, where you press down and then sit back on the heels. So like Ryan was in quadruped, you get into a little chin nod, press through the hands and sit back on the heels, like a child's pose.
For the ball, what position is
Oh,
that?
they're standing.
Oh,
Yeah,
just
so
the
you-
wall?
so pretty much
Okay.
like this, and go ahead and protract, and then roll it.
You can put a towel.
Yeah, towel works well too.
The ball rolls, so.
Yeah. And there again, I think patients a lot of times have a tendency to they want to go too far or do too much. And so just, there again, that's where that coaching and that hands-on comes into play from the therapeutic exercise stuff. Good one, I like that.
Well, I just want to say one thing about presentation. I think we get referred a lot for neck pain, and you get a patient that's referred for neck pain, and they're complaining of pain kind of right in the levator region. It's a deep, kind of boring pain. Go ahead and ask that question. Are you having you have headaches back here in that occiput region? And time after time, my patient will say yes. And your patient will think that's that tension headache that's normal, that they're supposed to have, that they take some Advil and it goes away. Well, a lot of times that's a referral pain point from subcranial dysfunction. And when you get that patient referred for neck pain without the headache, and they got a deep, boring pain kind of in that levator region, go ahead and screen that subcranial. You get that subcranial moving, that levator pain will go away, their headaches will improve, and you move up a notch your patient's book. And you can ask them that question, say, hey, you have a deep pain here, you got a headache here, that wraparounds? Yes, how did you know that? And that they think you're pretty awesome when you do that. So I looked in my crystal ball before you came back.
Chris Allison was demonstrating the
Yeah,
scapular retraction.
like for serratus, I like to get them against a wall or a column, because one, it keeps their posture in check. Two, you take your hands and clasp them together and take their thumbs and put it against the wall, bring your elbows together and then slide your thumb up the wall. That's tough, that's tough. So, I mean, that makes people sore, it's tough enough to make them sore. You can put a band too, you can do some work with a band, the same way, just squeeze the ball, squeeze the elbow. That's a good one.
Can you video that for us and put it on Facebook?
Sure.
I like those, by the way, that's great.
YouTube.
YouTube, yeah.
All right, anything else?
I was going to say one more thing. I read an article recently talking about cell phone use and talking about people looking down. And I guess typically if your cell phone's in your lap, if you're 60-degree angle, it was saying, like, I saw your chart up there that said your head weighs 44 pounds in this position. At 60-degree angle, your head weighs 60 pounds. So if somebody's like sitting there looking, that's going to create a lot of cervicogenic problems. So that's something I started talking to my patients about a lot. Just you walk out of the room, you come back and you're on your cell phone, like how much time are you using on the cell phone? Because if you've got to be on it, you got to change the position a little bit. That seems obvious, but I think it happens more and more now.
All right, so that wraps us up. Thank you guys, and Steve has an announcement or two.
Yeah, thanks for coming, and thanks to everybody that participated in this. This is great. We keep growing. We promise next time we do this, have a few more chairs for you guys that did the standing endurance test. I think you passed, so that's good. I'm really excited just to introduce someone to you guys. I sent an email a couple weeks ago that we were bringing on someone to manage our HR functions. And so Dina Agee started with us yesterday, and she came back today and actually came here.
That's a good sign, isn't it?
I told her it's good that our retention rate's going up with the HR position. But I just wanted to introduce you guys to her. She started yesterday. Should be a part-time position, kind of working something like 9 to 2 each day. So We were kidding about maybe not getting your phone number out today, and then the
I
reality
don't know
is.
it, so I really can't give
Yeah,
it.
she doesn't know what it is. So when we know what her number is, eventually we'll let you have it after we sort of get her oriented and settled in. But she's going to bring a lot of organization to just the HR function, and we'll be getting more information out to all of you about how to access her and utilize her in that way. So Dina, and I'm just going to let her to kind of just introduce herself, tell you a little bit about her, and then we'll be about them.
Well, I was excited that I started yesterday, and then today I got to meet everybody, so I'm very fortunate for that. When I met with Steve, I was excited about this opportunity. My background is in HR, and I'm friends with Sandy Edwards, as the email had said, and she had been telling me for years about how wonderful TherapySouth was, and that maybe one day there might be a position, and so I'm really glad to be a part of this organization and looking forward to working with each and every one of you. My background is in HR. I started out at South Trust in Human Resources, and then I moved to be the HR director at Vulcan Threaded Products and was there for 11 years. So Human Resources is what I love to do, just as you love to do therapy. So hopefully I can be an asset to the company, and I look forward to working with you all. And if you have any questions, just please come and see me. So thank you so much.
So welcome. We're really done, just in the way of kind of from here. I think there may be a little more food if you're still hungry. And then clinic directors, we'll take maybe 3 or 4 minutes, and then we're going to collect on that end of the ring to kind of redo the clinic director picture for the website. And I think that's it. Thanks, Scott, for food, getting food together and hosting. Have a great day. Appreciate it.